Muthu, you are live now.
Hello. Is my voice is audible? Okay, good afternoon. Yes. So due to technical issue yesterday, we cannot able to start the session. So now we are back to the protection series of pediatrics. So without wasting time, we will be starting the session. So what will be our first question? Okay. A neonate born at 34 weeks. You can see 34 weeks of gestation, weighing of 1.9 kg. Now tell me whether it is a normal birth weight baby or not. First thing you should tell that. And you think it is stable. So it is fine. Started on Gangaru Mother Care, KMC. Okay. After 6 hours, the actual temperature is 36.1. What is the best next step? Now tell me. So here, first and foremost, we know the normal temperature of the newborn, the neonate. Here, we are having hypothermia. Here, we are having mild hypothermia and moderate hypothermia and severe hypothermia. Okay, you know the answer is B. I am asking the question, what is about mild hypothermia temperature, the range? That is very important. Okay. So mild hypothermia ranges with 36 to 36.4 degrees Celsius. What about moderate hypothermia? 32 to 36 degree centigrade, that is Celsius. If it is severe hypothermia, it will be less than 32 degree Celsius. So here, in mild hypothermia, we are naming a term that is called cold stress. What is that? Cold stress. So the patient, the neonate, will be experiencing cold stress. So that we have to continue the KMC to maintain the temperature equilibrium and recheck the temperature in next 30 minutes. Okay. Yes. Always remember. So what does it provides? KMC provides what? KMC provides skin to skin warmth. And we are having thermo regulation. Okay, thermoregulation, and for stabilization of temperature we are using that. Okay, Cold stress. Yes, cold stroke also we can say. Okay. And sir, whether for low birth weight babies can be implemented or not? This KMC, yes, obviously for stable preterm and low birth weight babies also KMC is indicated. Okay, we can give. So what about A option? Start empirical antibiotic. There is no evidence of sepsis. Stability there, the neonate is stable there. Okay, why to give antibiotics? It's not there. So fast rewarming until temperature reaches 37 degrees Celsius. So rapid rewarming is not recommended in mild hypothermia. Why? Because it causes physiological instability. Okay, it causes physiological instability. Okay. Any other answers? IV dextrose infusion, is there any evidence? Dextrose for what will be giving? To whom will be giving dextrose? So dextrose will be giving if the neonate is experiencing any hypoglycemia or not. Hypoglycemia or not. Okay. What is the target hypoglycemia? If dextrose is indicated. If the glucose level goes beyond 45 mg per deciliter, then we can initiate this dextrose as per physician order. Okay, hypoglycemic state. Yes, right, correct. Can anyone say low birth weight of the neonate? Low birth weight, very low birth weight, extremely low birth weight. Yes, less than 45. Correct, correct. Shankar Raj, yes, correct. Sikta Rana, yes, correct, correct. You're all right. Yes. So when low birth weight is less than 2.5 kg, very low birth weight is 1.5 kg. Extremely low birth weight 1 kg. Till as per guidelines, low birth weight, this KMC is indicated. Sir, for very low birth weight baby also it is indicated. Yes, it is indicated with close monitoring. We can proceed this Gangauru mother care KMC. For extremely low birth weight, we should not give until unless it is stabilized, because less than 1 kg baby will not be like stability will not be there. Okay, the hemodynamics will not be properly working there. Okay, so that it is not indicated. Is it clear? Fine. Shall we move on to the next question? A scenario based question. A 2-year-old baby weighing 15 kg was brought to the hospital with the history of loose stools, is afebrile, and there is no blood in his stool. Okay, that is fine. So what is fresh blood in stool? This, come on. Then the baby is lethargic. On examination, eyes are shrunken. Keyword. During the skin pinch test, the skin retraction took more than 2 seconds. On offering water, the child does not show eagerness to drink and responds poorly. 2-year-old boy. So then, which of the following correct concerning the treatment dehydration in this child? Yes, hematogesia. You're right. Hematogesia. Correct. So now tell me what will be the correct formula here. First, identifying severe dehydration findings. lethargicness, altered sensorium due to that lethargicness is there. Shrunken eyes, according to the given scenario, which is the important sign for dehydration. And skin pinch test that you all know. Skin retraction will not do poor skin turgor. These are the signs of severe dehydration. Okay, yes. So first of all, for management of this given scenario for dehydration, what is the fluid requirement for the children? That is 100 ml per kg IV we are going to give. Here, this we are giving in two phases. Two phases, how we are going to give. Initial, will be giving it as bolus. Bolus is continuous, rapid infusion. And remaining normal IV we are going to give. Initial bonus 30 ml per kg, that is of first 30 minutes. I am going to give first 30 minutes. Remaining 70 ml and I am going to give in next 2.5 hours. Is it clear? So now tell me, what is the weight of the baby here? Weight of the baby here, they have given 15 kg, right? 30 into 30 ml per kg, that is the initial management. So 30 into 50, that I am going to give in first 30 minutes. So when we calculate this, it will come 450 ml. This is how you should calculate. So 600 ml to be given in first 1 hour, no. 600 ml to be given first IV in first half an hour, no. 450 ml to be given first half an hour, yes. 450 ml to be given in first hour, no. According to the scenario, the answer is 450 ml to be given as IV in the first half an hour, that is 30 minutes. Here, response to the eagerness to drink any fluid, to drink water, the child shows poor, responds poorly. Then how we can say that? Then how we can say? Okay. Yes. Shall we move to the next question? Third question. Which of the following milestones is expected to be seen in 3 years of age? Option A, telling stories, follows 3-step commands. And then what will be next thing? Knowing is our gender, going down on alternative feet. Good afternoon. Yes, good afternoon. Come on. Telling stories will be on which year? This is always a confusing question, I know. First of all, for 3-year child, what will be the milestone achievement? First of all, when we talk about language, recognizing, tell, name, age, gender. Recognize and tell name, age and gender. Whether it is a male or female, that gender identification is very important. That develops in 3 years. Gross motor, climbing upstairs. Okay, climbing upstairs will be developing in 3 years. Fine motor, anyone? Fine motor is drawing a circle, drawing circles and building towers. The tower blocks the child can able to build that 8 to 9 cubes that approximately we can say. Social, this related to play, parallel play. They will not gradually involve others, but once opposite another one child is playing a thing, so parallelly they can also play the same game while watching, while observing the thing. So that is the important thing of milestone development in 3 years. So I'm not confusing anybody, because if I am telling other plays, other age groups, because age specific, if 3 years are there, these are the important parameters you should know. Coming on to the options. Telling stories, it is a complex ability. Okay, complex ability will not develop in 3 years. It develops in 4 to 5 years. So it is in 4 years. So answer is not. Follow three-step commands. So it is an we cannot say that is a milestone. It comes under advanced comprehension. So higher skill level. So follows three-step commands will not, the child cannot able to do. Only one or two command. One command is fine. Okay. Yes. Knowing is or gender, obviously it will comes under 3 years of age. Going downstairs, alternative years. Climbing upstairs comes under 3 years. So 4 to 5 years, obviously alternative test going downstairs. So it develops in 4 years. Is it fine? Yes, correct. So the answer is C. So now you should brainstorm all the concepts. Okay. Whatever we are learning here, it is very important. So day after tomorrow is 10th and 11th is your exam. So please be prepared. Don't study anything new. Just practice MCQs as much as possible and revise your content. That is more than enough for your exam. I hope all the people have studied well, and your question paper will be like very easy to moderate only, not tough as per your prelims. Okay, it will be easy to moderate. Hopefully, try to attend more questions, so it will be very valid, and be conscious in attending in sections. Okay, yes. Downstairs is 4 years, upstairs is 3 years. Next question. A 2 month old infant is brought to the clinic for developmental checkup. Which reflex should the clinician expect to see at the stage of development? STNR. What is this STNR? Symmetric tonic neck reflex. Okay. Yes. Here we are having postural reflex and primitive reflex and protective reflex. So primitive reflex appears at birth. Postural reflexes not present at birth. After that, the reflex will develop. So protective reflex is like lifelong. Once it is appeared, it will be like protective. It will be like lifelong. So here we are having three. Okay, postural, primitive, and protective. Okay, yes. So this reflex, the first reflex appears 6 to 9 months of age after birth. So what is the question brought to the clinic? Developmental checkup, 2 months old. So which reflex should be at the stage of development? 2 months old child. Yes, Moro reflex will be there. So B is the answer. It appears at birth. So we are naming it as primitive reflex, and it disappears at 5 to 6 months. Parachute reflex, it appears at 7 to 8 months, and we are naming it as protective reflex, and it persists lifelong. Landu reflex, postural reflex, it is and appears at 3 to 4 months. Yes. So what about Landu reflex? Landu reflex 3 to 4 months, disappears at see it. The Moro reflex appears at 20 weeks to 25 to 30 weeks of gestation. Okay, 25 to 28 weeks of gestation, it will develop, but fully developed. The assessment part at birth, we can say though that we are naming it as primitive reflex. Okay, don't confuse between the appearance and fully developed things will be reflexes. Obviously, when we are assessing, it will develop at birth. Okay, yes, Lando reflex persists up to 1 to 2 years. So the answer is B. Okay. So what are the other reflexes? So started the Moro reflex started with subtle and sudden extension and abduction will be there, followed by flexion and adduction that you all know. Other than that, what are the primitive reflexes? We can say that is rooting reflexes there and sucking reflexes there 3 to 4 months. Rooting and sucking obviously at birth disappears at 3 to 4 months. Okay, yes. And palmar reflex is there, grabs one object at birth. Okay, yes. And plantar grasp, that is toes will curl on stimulation. So that is plantar reflex. So other reflexes shall I write here so that it will be very helpful for you. We are having other than that rooting, then sucking reflex, coming on to the palmar, then if palmar comes, then plantar and asymmetric tonic neck reflex is there. Okay, asymmetric tonic neck reflex. So coming on to the postural reflexes. Here, Landu reflex. Landu reflex. So what it does? When heads up, trunk will extends on prone suspension. Okay. So that is Landu reflex. And symmetric tonic neck reflex that you all know. It appears at 6 to 9 months and disappears at 9 to 12 months. So that is the first point. Disappears at 9 to 12 months. Yes, first disappears is rooting around 1 month. Yes, you're all right. So when we talk about this reflexes, it is a never-ending topic because we are having n number of reflexes, and when we consider in the MCQ discussion, as per the question, what is very important, that is enough. Okay, don't go beyond that. So it will be confusing for you all people. Okay, yes. Next question. A 5-year-old child presents with chronic constipation and hard bowel, stool, all bowel movements. Digital rectal examination reveals normal tone and the presence of a large fecal mass. The child is otherwise well. A contrast enema shows mildly distended colon with no clear transition zone. What is most likely the diagnosis? What is most likely the diagnosis? Is anyone? Come on. So what are the features? First, we have to write the features, what they have given. If you are having confusion in attending this type of big scenario question, I will give you the clue, or I will tell the trick which easily you can follow. You will be given with your rough paper, right? So first write the features. A keyword like say you can write whichever medium of language is fine. You can write it. First, what they have given: chronic constipation. First, write chronic constipation. Okay, first. What are the second symptom what they have given? Hard bowel stool and digital rectal examination reveals normal tone. Rectal examination shows normal anal tone. So now what will be the next? Presence of large fecal mass. So large fecal mass is there. And no systemic illness is there. So what about the enema reveals? So enema told mildly distended colon is there with no transition zone. So normally children's will be having 5-year-old children's will be having constipation. Okay. How we can say? We can say that is behavioral stool withholding. So due to that, fecal accumulation will be there. So that here you can see that mildly distended colon with no clear transition zone is there. So it will lead to this fecal accumulation will lead to clonic distension. Okay. Yes. So that what will be the option? No, it is not Eisenberg's disease. Here in Eisenberg's disease, there will be absence of aganglionic cells and transition zone will be present. Okay, here no clear transition zone is there and delayed meconium will be there in Eisenberg's disease. Here, 5-year-old child. Okay, so that the answer will be functional constipation. It is a behavioral stool withdrawing, withholding. Behavioral stool withholding. Coming on to the cystic fibrosis. In cystic fibrosis, there will be thick secretions followed by meconium ileus and there will be failure to thrive. What about anal stenosis? Narrow anal opening will be there. Difficulty in stool passing, especially from infancy, infant period, the child will not be able to pass stool normally. Okay. Yes. Here, the examination, everything is fine in the given scenario. It coincides with functional constipation. I hope this might be your question. It's like confusing question. What about generally I can say hard bowel stools is there and normal tone presence of large fecal mass. With this, people will think that it is an Eisenberg's disease. First, think, read entire scenario, write the keywords, then go for the conclusion. Without that, don't go for the conclusion. Okay. Yes. Shall we move on to the next question? Okay. So let me give you the clue for this Eisenberg's disease for easy identification. So what is the clinical form? The onset is like birth, from birth, and the meconium passage will be like here will be delayed. And what about the rectal examination? Empty rectum will be there. Okay, empty rectum. What about the imaging? When we talk about the imaging, it will show the transition zone. Transition zone will be there. Zone will be present. That is a key feature. A baby is noted to have diffuse ecchymotic swelling on the scalp immediately after birth, following a prolonged vaginal delivery, which involved a vacuum extraction. Which of the following is correct about this condition? Yes, come on, tell me. So now overall telling A, I need an explanation why it is A. It is a cephalhematoma features or like Capcut succedaneum feature. Yes, come on, tell me. Capcut succedaneum appears at birth or after birth. Here, a baby is noted to have diffuse ecchymotic swelling on scalp immediately after birth, following prolonged vaginal delivery? Prolonged vaginal delivery is there. See, Kapkan succedaneum will crosses the suture line, or cephal hematoma will crosses the suture line. So yes, it is Kapkan succedaneum. First, identify the condition. Don't confuse with cephal hematoma. Okay, Kapkan succedaneum is always superficial. Cephal hematoma is subperiosteal. It appears at birth. It appears after 12 to 24 hours. Okay, it crosses the suture line. It doesn't crosses the suture line. Okay, what about the size? Maximum will be seen at birth. Cephal hematoma increases after birth. The bulging they are saying, hematoma will always increase. Capcal succedaneum, once crosses the line, it maximum, once it is attained, it will be at birth. What about the resolution? Within few hours, it will resolve. Which, that is Capcal succedaneum. Cephal hematoma, it takes weeks. Okay. What is the risk factor? What is the cause when we talk about this Capcal succedaneum is? What is the cause? Pressure during delivery. Here, cephal hematoma due to instrumental delivery, any trauma. Any trauma. First of all, here, what are the features they have given? First, diffuse ecchymotic swelling. And another easy keyword is immediately after the birth. Immediately after birth, they have given. And prolonged labor. That also, because pressure due prolonged vaginal delivery also they have given. So it is clear that it is Kapkan succedaneum. So what is the feature coincide with it do not crosses midline. No, it crosses the midline. It maximum size at birth. Yes. It is periosteal swelling. It is a feature of cephal hematoma. It takes 12 to 16 weeks to resolve. No, it is also cephal hematoma. So the answer coincide with Kapkan succedaneum is it is maximum at birth. Maximum size at birth. Is it clear? So don't never think that it is a simple question we can answer directly. Scenario based question is always tricky. Always read the last line twice. Whether it is incorrect, whether it is correct. Now they have given this also. At least preference. Okay. These are some important words you should analyze while you are answering. Okay. Shall we move on to the next question? Okay. A 2-day-old term neonate presents with lethargy, poor feeding, and mild hypothermia. Okay, you suspect neonatal sepsis and order a sepsis screen as part of diagnostic workup. Which of the following findings would be included in sepsis screening for the neonate? Neonatal screening they are asking. Just come on, tell me. Which will be the answer? BB. Yes. All members should answer. Let me give some time so that you can comment. So what about this Mohiho chart? Moziho's chart. It is a clinical reference. to assess ANC. What is this ANC? ANC is like absolute neutrophil count. Okay, we are setting a target that is for very low birth weight babies. So ANC target is like 2000, 2000 we can say. Here we are categorizing neutropenia. According to CCT guidelines, neutropenia is there. If it is less than 2000 or 1500, we can consider. If it is between 1500 to 2000 cells, then it is stage 1 neutropenia, mild. Then it is between 1000 to 1500, stage 2. If it is between 500 to 1000, then it is stage 3 neutropenia. If it is less than 500, okay, sorry, less than 500, symbol correct, yes, 4. It indicates severe neutropenia. When we talk about neonates, this is always categorized with the patients who are under chemotherapy and who are under diagnosed with cancer. This is neutropenia standard guidelines staging. In neonates also, we are having this Mohizo's chart. Mohizo's chart. Okay. In this, we are categorizing the very low birth weight baby infants, very low birth weight babies. And especially we are categorizing these infants and we are monitoring whether the neutropenia is there or not and which indicates the clinical marker for neonatal sepsis. If there is high neutrophil count, that indicates, okay, there is a chance for sepsis. When the count is less, when the count of neutropenia, that is the count of ANC is less, then we can consider the immune response, the immunosuppressants is there. Okay, when the patient is taking chemotherapy, for example, methotrexate, vincristine, this type of drugs, for example, I am just telling, these drugs, all chemotherapy drugs cause neutropenia, but this mostly causes, okay, this methotrexate, low dose methotrexate, high dose methotrexate, this causes this neutropenia. Okay, yes. So now tell me what will be the answer. A, B, or C. So the total leukocyte count is greater than 5000 per mm and total leukocyte count less than 5000 per mm and increase absolute neutrophil count, decrease absolute neutrophil count as per Mohino chart. Here 2-day-old infant and term neonate. Lethargy, they have not mentioned about any important parameters for weight. And order a sepsis screen. You suspect neonatal sepsis is there and which are the indications there, they are asking. Okay. This total leukocytes count, if it is less than 5000 mm per cubic, then included into the sepsis. We are suspecting that, okay, this reflects bone marrow suppression or consumption during an infection. This indicates that. Okay, yes. So what are the other parameters we are naming it as? Now we are going to see the parameters. Neonatal sepsis screen. First point, that is total leukocyte count. If it is less than 5000 mm per cubic. See, this Mohino chart is for very low birth weight baby and from infancy we are going to categorize when for only the neutrophil count. Okay, this other than that, this neonatal neonatal sepsis screening is there, that is for TLC, total leukocytes count, and followed by ANC, absolute neutrophil count, that also will be decreased when total ratio neutrophil ratio is there, it will be like increased. What about this CRP? C reactive protein will be elevated because of sepsis. What about this micro ESR? erythrocyte sedimentation rate also will be like increased. Okay, these are the important parameters for neonatal sepsis screen. Okay, is it clear? So what the nurses should monitor? So first, because it is a 2-year old, 2-day old term in neonate. So first, the feeding pattern is important, and the nurses should assess the temperature, because hypothermia is most common in things. And activity, the lethargy will be there. Obviously, activity, the muscle tone also, the nurse should monitor. What is the important critical thing the nurses should do? Because early recognition is very important. Okay, before administration of any antibiotics, the blood sample should be collected, and strict aseptic technique should be followed. Okay, this is the important thing. Okay, shall we move on to the next question? Okay. Which of the following is incorrect regarding postnatal changes in circulation? Septum primum and secundum fuse, closing the ductus arteriosus. Loss of placental circulation closes the ductus venosus. And following cord clamping, the systemic vascular resistance raises. Higher pressure in the left atrium than the right atrium closes the foramen open. So this is quite simple question, but it is an tricky question. First of all, we will reveal the answer. So the answer is septum primum and secundum fuse, closing the ductus arteriosus. How? Because they have mentioned a term incorrect. Incorrect regarding postnatal changes in circulation. So when does the ductus arteriosus, the fusion of septum primum and secundum, leads to closure of what? Septum primum and septum secundum fuse will lead to closure of foramen oval, right? Leads to the closure of foramen oval, not ductus arteriosus. Okay. When does it occurs? When the closure of ductus arteriosus occurs when there is increased oxygen tension, O2 tension, and decreased prostaglandins. Okay, yes. So now tell me, when does this foramen oval close? Mechanism behind that. Functional closure at birth. Okay, functional closure at birth. Yes, foramen oval mechanism of closure due to increased left atrial pressure, which will be greater than right atrial pressure, and septal fusion will happen. That is the septum primum and septum the secundum fuse together. That is functional closure. So now we are going to see about the sequence of events after birth. So first is cord clamping. When the cord is clamped, there will be increased systemic vascular resistance will be there. Then obviously what will be the second? First breath. The baby, the neonate which is born, first breath, which decreases pulmonary vascular resistance. When the vascular resistance is down, the decreased vascular resistance is there, then obviously there will be increased pulmonary blood flow. When the blood flow is there, there will be increased left atrial pressure. When the left atrial pressure got increased, obviously there will be closure of foramen ovale, ductus arteriosus, and ductus venosus. Yes, correct. Decreased, yes. That's what I explained here. Closure of this ductus arteriosus always when there is an increased oxygen tension and decreased prostaglandins. Here you can see when there is a decreased that is the pulmonary vascular resistance is there, there will be increased pulmonary blood flow. When there is, then it leads to left atrial pressure, so that the oxygen tension will be increased there. So there will be closure of this foramen ovale, ductus arteriosus, and ductus venosus. Is it clear? Okay. So when we talk about the functional closure and anatomical closure, the functional closure of this ductus arteriosus always when functional happens is within 24 to 48 hours. Anatomical closure, it may take 2 to 3 weeks. Ductus arteriosus. And which forms ligamentum arteriosum. Okay. Is it clear? Shall we move on to the next question? So here, loss of placental circulation closes the ductus arteriosus. Yes, correct. When there is an decreased pulmonary blood flow, which increases the left atrial pressure. Okay. Following cord clamping, the systemic vascular resistance rises. Yes, correct. Higher pressure in the left atrium than the right atrium closes the foramen ovale. When there is an increased left atrial pressure due to this decreased pulmonary blood flow, obviously it closes the foramen ovale. So this is also correct. So the incorrect option is foramen ovale should be there instead of the ductus arteriosus there. Okay. Yes. We need speed. Okay. Next question. A child is brought to you because he cries excessively. When his limbs are moved on examination, the child refuses to move the limbs. There is generalized lymphadenopathy along with the maculopapular desquamative rash involving the palms and soles. X-ray of the both limbs shows periosteal reaction with osteochondritis. Which of the most likely the diagnosis? Yes, come on. First of all, you should, for this thing, you should write the clinical symptoms. First of all, what they have given, pseudo paralysis, refuse to move the limbs. Here they have given his limbs are moved when he cries. Okay. So what we can move, refusal to move the limbs. Second question, second point, what they have given generalized lymphadenopathy. Lymphadenopathy. And they have given maculopapular desquamative rash, okay, which involves palms and soles. Generally, I will put desquamative rash. What about the fourth one? X-ray shows periosteal reaction with osteochondritis. So here, according to this, what are the options? Congenital rubella, late congenital syphilis, and infantile cortical hyperostosis, and early congenital syphilis. Okay, yes. Congenital rubella will be having what? Congenital rubella will be having a triad of what? How you people are going to answer that? Here, congenital rubella will be having patent ductus arteriosus, followed by cataract and sensorineural hearing loss. Coming on to the late congenital syphilis. Yes, correct. Late congenital syphilis occurs after 2 years. That saddle nose will be there. Okay, saddle nose, that will be the clinical symptom. Infantile cortical hyperostosis. There will be bone swelling followed by irritability. No rashes will be there. Coming on to the D option, early congenital syphilis. Here there will be rashes, changes of bone and pseudo paralysis will be there. Within first 2 weeks, the features will appear, especially in skin, maculopapular rash, discoloration of the palms and soles, and bone, osteochondritis will be there, and pseudo paralysis that we are naming it as parrot pseudo paralysis. Okay, yes. Coming on to the late congenital syphilis. Late congenital syphilis, what will be there? Yes, come on. Tricky one, yes, definitely. Notched incisors and saddle nose, interstitial keratitis will be there. Interstitial keratitis will be there. This is after 2 years. Okay, yes. So coming on to the next question. Is it clear? So the answer is what? Early congenital syphilis. Shall we move on to the next question? Yes. A 30-week-old preterm infant is clinically stable and tolerating expressed breast milk via orogastric tube is being evaluated for readiness to transition towards oral feeding. On examination, the baby shows short sucking burst but poor coordination of suck swallow breathing. Which feeding approach is most appropriate at this stage? Come on. Which will be the answer? First of all, we will be reading the indication. According to the gestational age, less than 28 weeks or unstable, what will be doing? 28 to 32 weeks, what is indicated? Mode of feeding. 32 to 34 weeks, what is indicated? And more than 34 weeks, what is indicated? If it is less than 28 weeks, total parental nutrition is indicated. If it is between 28 to 32 weeks, NG tube or orogastric tube we can give. If it is 32 to 34 weeks, Paladai feeding we can give. Or other one thing is there, Katori spoon feeding we can give. If it is 34 weeks, more than 34 weeks, direct breastfeeding. Is it clear now? So now tell me, so what is the keyword? 30 weeks preterm and clinically stable, tolerating express breast milk via orogastric tube. Is being evaluated readiness to transition towards oral feeding. On examination, the baby shows short sucking burst, but poor coordination, suck, swallow, breathing. What will be the answer? See, already the baby, the preterm infant is stable and tolerating breast milk via orogastric tube. Why to maintain full orogastric feeds and supplements with intravenous fluid? Why to give that? Why to give this? Initiate bottle feeds with controlled slow flow nipple. Directly, we should not involve this bottle feeds and shift to only spoon or pollard feeds for all milk intake. No, we should not give that. It is risk for aspiration. Though because it is 30 weeks old, right? For 20 to 32 weeks, we can proceed with this orogastric tube feeding. Why to change that? Yes. So continue orogastric tube feed with occasional spoon or pollard feeding is enough. Okay, because it is showing the immature oral feeding skills of the newborn neonate, not fully ready for oral feeds. Okay, primary feeding via orogastric tube, and we can gradually transition. We can do here. They have put a word readiness to transition towards oral feeding. Towards oral feeding. Whether the neonate can able to tolerate that gradual increase is very important. Okay, that is the question there. Now the answer is C. Is it clear? Shall we move on to the next question? So what about the bottle feeds? Let me give you the quick recap. Okay, bottle feeds and only spoon or polarized feed. Orogastric tube and orogastric feeds plus IV fluids. Okay, requires coordination. Here requires coordination, bottle feeds. When you are giving bottle feeds, the child should also get consumed that. The neonate also should consume that. Okay. Only spoon or pallary feed requires better coordination. This also requires coordination. Okay. On tube matches the transition stage. Okay. On this oral fluids plus IV fluids, if the baby is stable and no indication for IV there. Okay. That's what these four options are telling. Bottle feeds requires coordination. Only spoon feeds also require coordination. On tube correctly matches the option. And D option, there is no indication for IV fluids. Okay, is it clear? Okay. Moving on to the next question. A newborn presents with yellowing of the skin on the face and sclera at 48 of age, hours of age. The bilirubin levels are elevated, but within the range expected for age. The jaundice gradually progresses to the trunk and extremities. Which of the following is the most appropriate management for this patient? Yes, tell me. So first of all, the neonate presents onset of age is 48 hours. Here they have given 48 hours. I will write here. Here is 48 hours. And bilirubin levels are being elevated, expected range for the age. They have not given the value, but it is more. So first we have to identify onset is 48 hours. Which type of jaundice is this? Which type of jaundice is this? First, we have to identify it is physiological jaundice or pathological jaundice. Physiological jaundice. Yes. Now tell me, what will be the features? After 24 hours, it will appear. Peaks at 3 to 5 days. Within safe limit for age. The bilirubin remains will be safer limits. And what about the resolution? The resolution will be like spontaneous. So what is the feature they have given? Here, from the face, starting from the face, then reaches the trunk, then reaches the limbs. The progress is like this. So then we can name it as cephalocaudal. It's not proximo-distal, it is cephalocaudal direction. Okay, yes. The progression, when it is pathological jaundice, the progression will be like gradual. When pathological jaundice, it will be like rapid. So what will be the management here? Because the elevated but within the range expected for the age, we can no initiation of this immediate exchange transfusion because rapid, this is for keratinic excess. It causes when there is severe hyperbilirubemia or with keratinic excess, we can proceed this immediate exchange transfusion. So it is not correct for this option, for this question. What about this IV administration of intravenous immunoglobulin? It is used in hemolytic diseases like RH incompatibility that we can use, not for this jaundice. So this is also not the option. Initiation of phototherapy. Because it is in normal range, why should we keep the patient neonate under phototherapy? So no need of that. So direct observation and reassurance is important. Okay. Yes. Only monitoring is enough. Okay, that's what the question says. So this is the critical thinking for you as a nurse. So first think as a nurse. So nurses, what we will do, we'll be doing the assessment, we'll be doing the observation, we'll be checking the checklist and finding the initial symptoms of the patient, and we'll be responding when there is an emergency. We'll be responding or we'll be taking a call to physician. Initial steps, that is important. Think like a nurse and answer. Here will be whether there is need for immediate exchange transfusion that the nurse can administer or not. Whether which is the most appropriate management for the patient they are asking. Okay. Yes. Shall we move on to the next question? Yes. You witness a sudden collapse of 3-year-old boy. What is the recommended maximal time to check for a pulse before starting CPR in the above boy? Up to 20 seconds, up to 15 seconds, up to 10 seconds, up to 30 seconds. Yes. C. Yes. What's the ratio for infant? Infant CPR ratio. For one rescuer, two rescuer. Infant, not neonates. Neonate is different, dear. Children. Children is different. That is for infant is different and for neonate is different. For neonate, we can say that is for 3:1. For infant, for one rescuer, it is 30:2. For two rescuer, it is 15:2. Okay, don't confuse between infant and children. And 3-year-old boy. This is for also children. Okay, when the neonate period is over, like 28 days, 1 month is over, they are considered as infant. This will be your critical thinking, critical question. So how we will be checking the pulse? Whether it is a newborn, we'll be checking in brachial region, or if we are going to check in the carotid region. Now, how we are going to check? 1001, 1002, 1003, 1004, 1005, 1006, 1007, like 1010. First, ensure the scene is safe. Okay, yes. Shall we move on to the next question? Yes. A 12-year-old child is brought for a routine bell baby visit. Which of the following findings should normally be present at this age? Tripling of weight, birth weight, building a tower of 6 blocks, ability to stand without support, and mature pincer grasp, 8 to 10 word vocabulary, waves bye bye. Yes, come on. I will give you a good time. You can just think. So weight double set, weight triple set, weight doubles at 6 months, triples at 1 year, quadruples at 2 years. Right? Yes. So first thing, 12-month-old, that is 1 year, weight triples. So one is selected. Building a block of six. Whether the child can do that? No. Ability to stand without support. Yes, gross motor development will be there. Obviously, gross motor development will be there. And mature pincer grasp. Fine motor development also will be there. What about 8 to 10 vocabulary words? So that is not possible. Okay. Waves bye bye. Yes. So what is our answer? 1, 3, 4, 6. Yes. Okay. 8 to 10 words the child can speak at 18 months, at 1.5 years. Tower block, already I told, it is 2 to 3 years process. Okay. Tower block of 10, 9 to 10, that in 3 years. Okay. Yes. Why B? The answer is D, right? Yes, the answer is D, no B. Okay. Yes. Okay. Height double set. Yes, this is your question. Yes. Height double set 4 years. Correct. Correct. Not 5 months. No, 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 no. It is 4 years. 4 years. Yes. Next question. A primigravida delivered a baby at 34 weeks of gestation. The baby was cyanosed and grunting with a respiratory rate of 72 beats per minute. Which of the following scores can be used to assess this condition? Downey score, CRIB score, SNAP score, and Silverman Anderson score. Yes, come on, what will be the answer here? Cyanosed grunting with respiratory rate of 72 beats per minute. So it is high. What is the score can be used to assess? So Silverman Anderson score. What about the CRIB? That is clinical risk index for babies. What about SNAP score? Score for neonatal acute physiology. So first of all, it is mainly for older infants. This Downey score also assesses the respiratory distress score, but for older infants. but for older infants. What about this CRIB score? Assess mortality risk. What about this SNAP score? That is illness severity in NICU, neonatal intensive care unit. This also not covers under this respiratory illness. So what about this Silverman's Anderson score? This is specifically for neonates. What will be the maximum score we can give? We are having parameters. That is score ranges. We are having five parameters. Five parameters. Maximum score that is of 10. Silverman. Silverman Anderson score. Five parameters and maximum score is 10. You want me to discuss that or not? Shall we proceed with the next question? If you want, we can discuss Silverman Anderson score or we can proceed to the next question. I am letting it on you. You people can say so that we will discuss that. Because I don't want you to confuse because they won't ask that much in detail. Just you should know what is Silverman Anderson score. That is enough. Like Abgar score, what we will do. Abgar score is very important. That nurses will do. But Silverman Anderson score, that physician are more trained to do this. We will be just a secondary observer. We will discuss. Okay, discuss. We will discuss that. We are having the parameters of five. Upper chest movement. Then obviously lower chest retractions. And xiphoid retraction. What about next? Nasal flaring and expiratory grunt. So here, when the upper chest movement synchronizes, will give giving a score of 0. 1, 2. When upper chest movement lack on inspiration, then we'll be giving a score of 1. Lack on inspiration. When the upper chest movement is like seesaw appearance, then we'll be giving a score of 2. Lower chest retraction, when there is none retraction, will be giving no. Just visible, then we can give a score of 1. When it is a marked visible, then we can give a score of 2. The same thing for xiphoid retraction also. The same thing for nasal flaring. In nasal flaring, if there is minimal nasal flaring, then we can give a score of 1. Marked thing. Here, marked. When there is a minimal nasal retraction flaring, then we can give score of 1. When it is a marked thing, then we can give a score of 2. What about expiratory grunt? Grunts always will be visible, audible with stethoscope. Okay, while when we do that, when it is expiratory grunt is audible, then we can give a score of 1. Audible without stethoscope itself, then we can give a score of 2. With stethoscope, without stethoscope, if it's audible, then we can give a score of 2. So what is the score range? If the severity of the score is between, when the score increases, the severity of the respiratory illness will be like increase. Distress is more. When we talk about the features, neonatal features, what are the neonatal features? Tachypnea and grunting, retractions, nasal flaring, and cyanosis. These are the features where the neonates will be experiencing respiratory illness. Okay, is it clear? 15th question. A 3-month-old child was brought to the child health clinic with his own twin brother. The clinical history reveals that the child is being artificially fed and the birth order was found to be 5. Records indicate birth weight was noted 2.8 kg. Which of the following would not be a criterion for identifying this baby as an at-risk infant? At risk means what? First, identify with the given data. The age is 3 months. Okay, first thing is 3 months. Artificial feeding is there. Okay, twin pregnancy with his twin brother, and birth order is 5, and birth weight is 2.8 kg. That is normal. So, what are the key factors of at-risk infant? 2.8 kg. Which of the following would not be a criterion? Not be a criterion for at-risk infant. Artificial feeding is there. Will be there. First of all, let me discuss at-risk infant. Nutritional factors will be there, prenatal factors and environmental factors. Artificial fed, obviously it will be in criteria. Twins, obviously it will be in criteria. Birth order is more than 5 or more, so also will be in criteria of at risk. These are at risk. Which will be not? If the birth weight is less than 2.5 kg, then we can say it is an at-risk infant. The cutoff risk is 2.5 kg. The weight is 2.8 kg here. So the answer will be D. So the answer is D. So what are the markers? That is biological. This is also important key thing you should note. Biological, nutritional, perinatal, and social. Okay, yes. Shall we move on to the next question? Which of the following statement is not true regarding the tape in the given image? First, what is a tape? Which tape it is? Shakir tape, yes. Which is to assess the nutritional status of the child. If it is less than 12.5, okay, the target is like more than, it should be like more than 12.5. If it is less than 11.5 also, we can consider the child is malnourished. Okay, yes. What is the answer? So what is the green zone here? Green zone is what? So what is the target here? If it is 12.5, we can consider this in yellow zone. More than, that is moderate. Moderate, I will write here. 12.5, moderate, acute malnutrition. If it is 11.5, less than 11.5, then we can say it is severe. What is the color? Red. Here it is yellow. Then if it is more than 12.5, that is 13, we can say it is green zone. Here yellow is like moderate. When it is more than 11 less than 11.5, then we can consider that is severe acute malnutrition. Okay, that is the important thing that you should know. Here it is severe acute malnutrition. It is moderate acute malnutrition. It is normal. Same thing. Okay. Mid upper arm circumference. We'll be assessing with mid upper arm circumference. So what we'll be telling acute malnutrition as wasting. What is the term for wasting here? According to the weight, according to the age, there should be weight and height. Sorry, weight for height. That is weight for height. Height for age is like shunting. Here it is wasting. Okay. Yes. Now tell me what is the answer. It is used age between 5 to 59 months. Yes, we can use. Here the keyword is not true. Please consider the question. Always read 2 to 3 times. Yes, correct. What is the answer here? Reading in the red zone is considered to be severe chronic malnutrition. Chronic malnutrition always with height, not with the weight. Muscle distribution, we cannot able to identify that. Reading in yellow zone is considered to be moderate acute malnutrition. Yes. Reading in green zone to be considered as normal. Yes. So chronic malnutrition always cannot be designated with the malnutrition with mid upper arm circumference, especially with this tape. Okay. That is with height for age. For the age, the child should meet the height. For example, the height for a normal 4-year-old baby, 4-year-old child, we can consider as 75 to 85 or 75, 80 to 100. The child should meet that. If it is not, then we are considering it as a malnourished child and it is severe chronic malnutrition is there. Okay. Yes. So the answer is B. What will be the next question? The growth chart of a given child treating changes in head circumference is shown below. Which of the following conditions is most likely suffering from? Phenylketonuria, hypoxic ischemic encephalopathy, achondroplasia, fetal alcohol syndrome. Here, the head circumference is above 97th percentile. Head circumference consistently above the percentile, that is greater than 97 percentile. Okay, 97%, 97th percentile. So disproportionately larger head size to the normal growth curves. According to that, what are the features we can say? Macrocephaly is there. Macrocephaly, mega, here I will write here. Macrocephaly is there. And skeletal dysplasias is there. Skeletal dysplasias is there. And what are the important things here? Disproportionate short stature along the relatively larger head. Head circumference. This is the head circumference. It is going beyond. Phenylketonuria, there will be no macrocephaly, there will be decreased brain growth in phenylketonuria. Decreased brain growth will be there. See, reading off a question, even I do the same mistake. See, this is the excitement when you are answering some 10 to 15 questions as a right answer. Obviously the 16th question you will think that okay, this will be our correct answer. Like that you will read the half the question and you will answer. Always remember, be cautious. Always write the key terms what they have given. Not is there or not, at least preference. Okay, not true, false regarding, incorrect option, like that. Always identify the keywords. That is very important, and write the features, clinical features. If like questions are there, try to identify the options. First of all, write the features, what is exactly given in the question, then go for the conclusion, then go for the answer. You can spend good number of 1 to 2 minutes for a question. Good number. Good time you can give for 2 to 3 minutes so that you can answer accordingly. Okay, yes. In phenylketonuria, it is a metabolic disorder. Brain growth will be decreased. What about hypoxic ischemic encephalopathy? It is due to the brain injury. And microcephaly will be like later, not macrocephaly. Here, achondroplasia, where there will be increased percentage, the proportion of the head circumference will be like increasing. So also associated with skeletal dysplasia. So the option will be like correct. C is the answer. Why not D option? It is teratogenic and it causes microcephaly. All this phenylketonuria, microcephaly, hypoxic ischemic encephalopathy, microcephaly, and fetal alcohol syndrome, microcephaly. Only condition achondroplasia above the proportionate of a persistently high head circumference fits the option achondroplasia. So the answer is C. Is it clear? Okay. So head circumference will be like plus 12 2 SD, greater than 2 SD and above 97th percentile. Okay, microcephaly minus 3 SD. That is microcephaly. Okay, yes. So what about the brain growth? Usually the intelligence level for the children with achondroplasia will be like normal. Only there will be limbs will be that is short limbs. Limbs are shortening and larger heads will be there. Okay, yes. Next question. Which of the following is false? Okay, false regarding secondary lactose intolerance. Lactose intolerance. Breast milk should be stopped. Cause is acute gastroenteritis. Is it transient and measured by H2 breath test? First of all, false regarding. You have to answer. False regarding. See, plus 2 SD, that is for head circumference. I am talking not about malnutrition. Don't confuse between head circumference and malnutrition. Here, if it is macrocephaly, it will be like plus 2 SD. If it is minus 3 SD, microcephaly. Okay, yes. What about 18th question? D answer? No, just think an answer. Here, they are given false statement. Breast milk should be stopped. Whether we should stop if the child is having lactose intolerance, then how the child will be having nutritional. See, if the child is having breast, that is lactose intolerance, it is due to secondary lactose intolerance occurs due to damage to the intestinal mucosa, and it can cause after acute gastroenteritis. That is also one of the important thing included. Here, breastfeeding, if the breastfeeding is stopped, how the nutrition will go? Breastfeeding always promotes for better gut healing and provides immunological protection. Obviously, it is indicated. No need to stop breast milk there. But it is a cause of gastroenteritis. Yes, it is transient. Obviously, it is not. There is no indication to stop breast milk there. And measured by H2 breath test. Yes, we can do that. So the answer is A. We should not stop the breastfeeding. Okay. Yes. Should continue the breastfeeding. Okay. Yes. Next question. The device shown in the image can be used in children up to. What is it? Given thing is there. It is called, here we are having infantometer and stadiometer. B. Infantometer we can use up to 2 years. Stadiometer greater than 2 years. So the answer is B. Okay. The last question of the session. The last question of the session. Yes. A male neonate of a diabetic mother presents with progressively deepening cyanosis and tachypnea since birth. On auscultation, an ejection systole murmur was heard at the left mid-sternal border. Is chest X-ray given below? What likely the diagnosis? First of all, identify the answer. Here, transposition of great arteries, tetology of Fallet, Epstein anomaly, total anomalous pulmonary venous connection. A option, B, C, and D. How we can say it is TGE? Here, egg on side, egg on side, and egg on string appearance, egg on side appearance. Okay, and there will be cardiomegaly. Okay, yes. Now tell me what is the answer? It is TGA, transposition of great arteries. In total anomalous, in total anomalous pulmonary venous connection, there will be snowman sign. In tetralogy of Fallot, there will be boot-shaped heart. For Epstein anomaly, massive, that is tricuspid valve defect will be there. Okay, yes. Yes, tricuspid valve defect. In TGA, there will be early severe cyanosis. You people have read lot of concepts. I know. Okay, lot of concepts. Don't confuse yourself. That's what a small advice from my side. As of my experience, I'm just telling. Once I cleared prelims and mains, so how I felt. So with minor mistakes, your rank will go back. You may think one question. No, brother. It is 0.5, 0.1. Your rank will go behind. Even if you're giving a negative marking, that is also very impactful. It will change your rank. So be cautious in answering. I am not threatening you people. I'm not making you afraid. I'm just telling. First, the key principle for attending an MCQ is like, first of all, read the question twice. If it is scenario based, while you're reading a question, you will be identifying the keyword, like features they have given. A child came to the hospital having this type of features. Just write the features. Just write the features, given features. If you know, answer, or else leave. That is a simple thing you can do. Then this for 2 days, you are having some good 20, 24 to 30 hours. Okay, tomorrow you are having a whole day. So how you can prepare yourself? That's what I'm going to say you people. First of all, revise the concepts. Starting from HN, if you're starting from adult health nursing, till the 5 core subjects is very important. Like adult health nursing, followed by OBG, followed by pediatrics, followed by community health nursing, mental health nursing, and fundamentals. These 6 subjects, whatever notes you have, you just give a glance. Then tonight and practice more MCQs as much as possible, like good numbers of 200 to 300 MCQs, that is fine. And try to recall yourself. Okay, then go for your non-nursing subject. If you are having time, nursing education, nursing management, you can have a revise. Don't read anything new. Don't read anything new. Whatever you read, if you are well prepared, just revise your content and go. That is more than enough. And be confident. Don't be overconfident. Be confident in giving your answers. Be like, you should be clear. Once you read the question, your concept should be in your mind and you should see the answers in your option. Just click the answer and come. Never ever change the option once you have clicked. Okay. This was the important thing. I will be writing here. You can see section 1, section 2, 3, 4, and 5. Till his, we are having nursing subject. This is non-nursing. If your mind is blank, then you are well prepared. That's what my opinion is. If it is a nursing, this is nursing part 1, 2, 3, 4. So 20 questions each and 18 minutes. 20 each, 20 each, 20 each. Try to attend less number of questions. Like if it is a tough portion, consider these 2 sections will be like tough. Moderate questions will be there. Try to attend less questions. In this 3 to 4 sections, in this 20, try to attend more than 38. Here you can attend more than 30, 38 questions you can attend. Try to attend more question in the nursing part itself. You can leave questions in non-nursing part. Try to attend, if you are well prepared, you can attend more than 13 to 15 questions there. Don't go beyond that. If you are not prepared, sir, I just have a glance in non-nursing subject. More than 10 to 12 is enough. 10 to 12 questions is more than enough. Not more than that. But try to attend more questions in your nursing part. Considering this, I have attended some 30. Here I have attended some 38. So it comes 68. So here I am attending some 10. So 78 questions I have attended. In that, you should attend more, like more than 80. If your question paper is easy, you should attend more than 80 questions. Okay. Yes, that's what I want to clarify you people. Just be calm, be clear, and you have done your best. You have given your best. Obviously, the question paper will be easy for all people. Okay. Better you people, the same session will be conducted 2 weeks after. The same people who are attending, who have watched the video, will be having the same prediction series for mains, and hopefully you will all crack the exam. All the very best from my side, from NNL family also. Okay. Thank you all.